I hope this talk is sort of a talk of two halves, really. So we're still going to be, I'm going to be looking, as I said, at the gaps, at variations. It's a bit of a theme that we've been hearing throughout the talks we've heard already for our very eminent speakers. But I don't want it to be all doom and gloom, because actually there's some positive things that's happening, and especially some of the comments that have been made, especially from the floor throughout the day, that actually, you know, there is a lot of collaboration going on, and I'm making that happen because actually this is how my post came about. So I'm a nurse by trade. I'm the first nurse on the stage today, so it's great to have followed our other speakers, and I think it really does sort of sum up, actually, with all the challenges, with the difficulties with diagnosing, the misdiagnosis, the treatments, the shooting in the dark. Actually, you want that to be by a specialist. So the reason I came into post was with Epilepsy Action and Epilepsy Society came together, and we realised that there was variations in services and for people with epilepsy. And actually, how could we address that? So initially, my title wasn't all that, it was super nurse. So I did get that changed pretty quickly, because I thought my colleagues actually wouldn't like that. But actually, could we parachute somebody in to actually look at these variations and try to address them? Because there are a lot of variations. So this is why I came into post, this is why I'm here, and it is a true collaboration. And usually I go around the country doing this talk, and beside me I have Perry O'Connor from Epilepsy Action. So it seems a bit strange doing it on my own, so we'll just imagine that she's here with me. So when we're talking to commissioners, Professor Sandra's already mentioned CCGs, clinical commissioning groups. There's 211 of them around the country. We are talking England. Now, I did do a little check before I did this presentation. People probably can't see me very well. And I know we've got some people from Guernsey here, we've got some people from Scotland, and one person from the Isle of Man. So, you know, this is predominantly, the CCGs are England-based. And I've done my research, I've got a bit to weave in about the other countries. But actually, when we look at England and the way commissioning is going, I think I'd rather be in some of the other countries at the moment. So it's a challenge. It is a real challenge. And neurology, to get neurology on the spotlight, so not just epilepsy, we have to talk neurology. Clinical commissioning groups, they do struggle looking at what they consider the smaller conditions. Actually, there's a bigger impact. So quite often we do have to talk the bigger numbers. So for neurology, this is a couple of graphics that were taken from Neurological Alliance. We have an organisation that has 80 members, which we're part of as well, so representing neurological conditions. So we can see here that over 700,000 emergency admissions recorded. That's £750 million spent. So it is a lot of money that we're talking about. So the Association of British Neurologists, they published a survey in 2014 looking at the provision of acute neurology services, and there's a 39% gap where people have got, well, the district general hospitals have got little or no acute neurology services. And again, from everything we've been hearing about, we need that to happen, and some of you may have that experience. This one I like, and especially what we've been hearing about today, the individual long-term conditions. So that involves people with epilepsy. And okay, this may vary a bit, but 3 hours every year spent with a healthcare professional. So the other 8,757 hours, you need to look after yourselves. So it is about that. You can look at this from both angles. Those 3 hours have really got to count. So you've got to make sure the system's set up and that you're getting value for the hours that you're going to be seeing healthcare professionals. But also, that care needs to be set up, and there was a mention earlier about the Epilepsy Action coffee and chat groups. We put together some self-management groups. It's important to have that lifestyle advice as well, so you can actually get on and live with the condition. So, again, this isn't a positive statistic, but this is where we are with epilepsy. So Epilepsy Action did a survey in 2014 where they surveyed the 211 clinical commissioning groups. 204 responded, and 78% of them stated they had not produced or they had no plans to develop a written needs assessment for health and social care with people with epilepsy in their area. So again, this is sort of stacked up against us. So there's 22% that are doing something or have got an interest to do something. So mind the gap. So, you know, there are gaps. And this probably doesn't encompass all the gaps that are out there. And I'm going to focus on a few of them as I go through the slides. But we've already been hearing already there's the seizure freedom variation. There was a Public Accounts Committee report done last year, and it's been published this year. I'm going to talk a bit more about that. We've got 25% higher incidence of epilepsy in areas of deprivation. We've been hearing a lot about the avoidable deaths, the 39% from the National Sentinel Audit. We started touching on nurses, and there was a report done in 2010 by Fiona Irvine that recommended there should be 1,100 epilepsy specialist nurses for everybody to get access to an epilepsy specialist nurse. And at the moment, again, we don't know exactly, but they're probably about 250, and we're still at 250. So we're a long way off our target. Also, we're hearing threats, and I hear quite a lot of threats about nurses being down-banded or made redundant. So it's still that challenge to actually keep the nurses in post. 60%, this came from the Critical Times audit, 60% of trusts don't have an epilepsy specialist nurse. So there's a real need to drive those up. Neurology, as I said right at the beginning, it's not one of the top areas, top 6 priorities for the focus for the 5-year forward view. And this is Simon Stevens, who's our Chief Executive of NHS England. So again, we've got to try and raise the profile of neurology and keep it up there. The Royal College of Physicians, they had epilepsy as a clinical priority from 2013 to 2016. That was removed early in 2015. So we lost that. We've got the neurology National Clinical Director for Neurology, Dr. David Bateman. His post is under threat. So it's great that we've got him, but it is under threat. We've got high A&E admissions. And with the clinical commissioning groups, they have got competing priorities. There's no new money out there. So whenever I talk to commissioners, actually you've got to make, either you've got to provide a return for our money, you know, and make money, and save money. But there's no new money to invest. So these are some. So with all those considered, let's look at some of the variations. And variations is quite a common theme going through this talk and some things we've heard today. So Public Health England, they've pulled together it's called NIN, a Neurology Intelligence Network. And on there, there's all information from about hospital admissions and about seizure freedom rates. So they've pulled that together. And what it has shown is that it's indicating there's pockets of excellent care, which is great, but then pockets of very poor care. So if we look at the rate of people who are seizure-free over a 12-month period, pick it out, but on the previous slide, we did have, for epilepsy, 3 quality outcome framework indicators. So none of the other neurological conditions have got them. So we thought, great, but actually we've lost 2 of them. And one of those was this, where we could look at an outcome to see how many people have been seizure-free over a 12-month period. Now, because that went 3 years ago, but we're still using some of the data for it. So we can then see where the variation is. So from here, we pulled through the figures, and you've got it ranges from a high of 87.1% in southwest Lincolnshire CCG to a low of 46.5% in North Manchester CCG. And saying low, that still isn't good enough. And that from what we've been hearing already, we know that, you know, with good treatment, with optimal treatment, 70% of people can be seizure-free, but it is around the 52%, so you've got the 18% treatment gap. So even the low of 0.5% isn't quite hitting it, and the English average is 61.1%. So this clearly shows us it's the work that needs to be done. Epilepsy emergency admissions. Epilepsy does count for the highest rate of emergency admissions with people coming in with seizures across all the neurological conditions. And even with other conditions, we top asthma and just about diabetes as well, which we're always sort of trying to follow. So it just shows the sort of the gravity of the situation and how care can be improved. So from as low as 52.8 in Newsbury district, CCG, and as high as 227 if you're up in Yorkshire and the Humber. And in England, average is 120. So we know not all of those admissions can be avoided, but a substantial amount can. And as we've been hearing already about the epilepsy mortality rates, so there's a variation up to 67% between CCGs. So on some survey findings, I've just previously mentioned about Epilepsy Action's Critical Times report in 2013. So 20% of adults are diagnosed by an epilepsy specialist. And again, what we've been hearing already from our professors and consultants is that, that really needs to happen to reduce that misdiagnosis rate. People need to be diagnosed by an epilepsy specialist. And only 7% of those diagnosed were within the 2 weeks. So the NICE has quality standards that people having a first seizure should be seen within 2 weeks. On the other end of the scale, you've got 7% that have waited more than 32 weeks. So there's more risk of people having seizures within that time. 52% of people with epilepsy had ever seen an epilepsy specialist nurse. And again, if we haven't got many of them, that's worrying. And 36% of women with epilepsy of childbearing age have not received information or counselling on contraception and pregnancy. And again, that was another QOF that has been taken away, the two that were retired, that we don't have anymore. So we don't have that, that we know people are, the GPs at least, are reviewing women. So we have some audits that have been taken place. We've got the National Audit of Seizure Management in Hospitals, the NASH report. So this is run twice. This was in 2011 and 2013. And what they looked at was the hospitals were looking at people who presented to A&E and looking at the whole care surrounding that. So the audit collected data from 8,000 presentations of seizure with to 150 acute hospitals across the UK. So this does go beyond England. And again, the word that's coming through again and again, it's that wide variability covering the entire care pathway and the need for better organised and accessible care for patients with epilepsy. And they recognise the challenge for clinical commissioners and healthcares, but there's an opportunity to reduce that 40,000 seizure-related admissions that occur in England hospitals that we know about. Epilepsy 12, so again we're looking at, this is where we're looking at children and young people. This audit was 2 rounds, again 2011 and 2014, looking against 12 markers which aligned to the NICE quality standards. As a bit positive, slightly positive news here, that actually, between these 2 audits, there has been some improvement. So more units have reported having an increase in a children's epilepsy specialist nurse. So in round 1, there was 53%. In round 2, there's 68%. Still, we'd like to see round 3 going up even more, and but round 3 will be underway shortly. So that's good. So I mentioned earlier about the Public Accounts Committee. So that's in 2015, they collected to look at actually what has happened since the last, the National Audit Office do a report on the state of neurology services. And what came out this time was that neurological conditions are not a priority for the Department of Health and NHS England, and concerns that progress may not be sustained. So progress means that actually something has happened since the last Public Accounts Committee report, and it has. So we did this is where we got the National Clinical Director for Neurology, David Bateman, and he has been instrumental in tasking strategic clinical networks, there's 12 of them around the country, to actually look at epilepsy and address epilepsy services, as well as rehab for other neurological conditions. Also having the strategic clinical networks themselves, we didn't have one for neurology, and so neurology was actually put in with mental health and dementia, so at least we had a focus there. And also data. So it was a call to get some data, and better quality data that we'd had before, but with the government put together a compendium of data, neurology data, and that's what Public Health England are using, which we described before. So that was progress. But services for neurological conditions are not consistently good enough, which we've seen. There remains wide variation across the country in access, outcomes and patient experience. So hearing what patients are saying about services. Diagnosing neurological conditions takes too long. Services in hospital are variable. Again, that the word comes through. And local and social care services are often poorly coordinated. So what they've recommended is that the NHS England should retain the role of the National Clinical Director for Adult Neurology, that's Dr. David Bateman. We'll hear in April whether that role is staying, and by NHS England should set out by April 2016 how to reduce the variations in services and outcomes, and holding clinical commissioning groups actually to account for their performance, and especially around neurology. The department should report back by April 2016, so not far away, setting out plans how it plans to link health and social care data, because there's a real gap there. NHS England should set out clearly by April 2016 which neurological services are specialised services to be commissioned by NHS England, and which services should be commissioned by local clinical commissioning groups. So we do have a variation in what services are commissioned and by whom. So looking more at co-commissioning. The department should confirm how it's measuring performance against the objective that everyone should be offered a personalised care plan. And what the report found was that 11% of people were offered a care plan or had a care plan. And I think it goes back to Professor Sanders' presentation about that detailed plan needs to be put in place. So NHS England should report back by April next year, 2017, on what's been done to make best use of available neurologists, the ones that we've got already, and reduce the variations in access, including through redesigned services and making sure that other clinical staff, particularly specialist nurses, are used to the full potential. So that's a bit about actually where the gaps are and what we're looking at. So now what we want to concentrate is actually what's being done. So we've heard already, Helen opened up with the campaign that's we're doing it through Epilepsy Society, and seeing a new national clinical audit, and that's following up from what Fergus Raggun was talking earlier about the National Sentinel audit that was done in 2002 by Juliet Ashton. Can we see any changes in that? So looking at the scale of the problem, the factors that contribute to the avoidable premature death, and whether there are any hotspots. So again, we're seeing the variations earlier for particularly high levels of premature death. And I did a check, and actually we're up to 1,200 people who have actually emailed their MP. So that's a result. So this is my bread and butter. So with all those challenges, and I go around the country talking to clinical commissioning groups, and saw right earlier on, there's 22% who are interested. 78% have not got epilepsy on their commissioning plans. So how can we do something about it? So it could be me going around the country, talking to these groups, trying to make them look at the data, look at the evidence for epilepsy. And that's a big ask for across 211 CCGs. So what we did And Epilepsy Society, Epilepsy Action came together, and we've designed a epilepsy commissioning toolkit. So it's the first of its kind. It doesn't exist for any other neurological condition. We did the research to find out, okay, is there anything else? Is there anything else out there? We looked at other toolkits, and some of them look great, but then they went out of date. So what's really important with this is to keep it up to date, keep the evidence within the toolkit. And this again comes from discussions with commissioners about what do they want to see, what evidence do they need. They don't understand. They don't understand neurology. They don't always understand epilepsy. So and there's so much data out there, and different papers and reports and tools all over the place. So what we wanted to do is actually bring everything together into one place. And this is it. So it is a website, and you can link onto it, register onto it. And what we wanted to do was work with the commissioners to actually go through the steps of commissioning. So I worked, in my first year in this post, I was seconded into the Vale of York CCG for 2 days a week. And we were looking at epilepsy and neurology services as well. And it just became clear, why are we doing it in this way? And actually, what were the challenges between the commissioners and the providers? So the healthcare professionals, the neurologists, the nurses, the hospital, you know, were they speaking the same language? And it became clear to me they didn't. So I had to become bilingual in both NHS speak and commissioning speak, just to make sure people actually really, really understood where we were coming from. So, and I think the most important aspect, so this goes through 9 sections and 9 steps, really, of what needs to be done with commissioning. And I think right from the beginning, it is that scoping what needs to be done. What does need to be done? You know, are things okay? And it's about people coming together. So it's the healthcare, the consultants, neurologists, nurses, people with epilepsy and families and commissioners right from the beginning, so you know what actually everybody's looking at. And then just as a start, as you click through each of these sections, I'll go through them a little bit in a minute, what information is there? What information is out there? Where should you be looking? How do you know where to start? So from the beginning, commissioners have what's called joint strategic needs assessments. They've got their commissioning intentions. They're all publicly available documents. So it's recognising what those documents are, and does epilepsy feature? So if epilepsy doesn't feature, does neurology feature? Are there any hooks to know that they've got an interest? So as you go through, there's data analysis is the next one, and this is where, again, it links to the Neurology Intelligence Network site, and this is where the data can be found on hospital admissions and on the seizure freedom points as well. Map current service provision. So what actually already exists? And it's quite interesting when you look at the contract that exists. So the commissioners will have a contract for neurology and epilepsy services, but some of them can be very short. Some of them aren't even signed. And then actually, if you look at those contracts, to actually what's being delivered can be quite different. And making sure you're getting that involvement of everybody to see what the provision is and where the gaps are. Co-production. This is a bit of a buzzword. Not many people actually understand what it means, but actually co-production, it shouldn't come here, it comes all the way through the steps, is involving people with the condition. So involving people with epilepsy right from the beginning in making those decisions. Not, as we quite often see, a tokenistic approach where you have a stakeholder meeting where you'll get a few people in who have got epilepsy and families. It's actually doing that right from the beginning. Service model, so agreeing what service is going to look like, right from primary care through to secondary acute care and tertiary specialised care as well. Business cases, so how can you make the use of the resource that you've got, or making a case for extra resource, and again, no extra money, so actually how's that going to work and what the outcome is going to look like. Service specification. So how you agree that the process, ownership and collaboration that needs to take place, and put that in writing. And then there's you'll then contract the service with the national template, but looking at some key performance indicators as well. And a lot of that time it is reducing unplanned admissions. And then if you're lucky enough to get all the way through to implementation, what I found is that can take a long time. So again, this is the other reason to get all this together, is actually let's try and speed up this process. So implementation, it doesn't stop there. So if you are implementing any part of an epilepsy service, be it an epilepsy specialist nurse, psychology input, neurologists, any aspect, how do we monitor that it actually works? And we've seen, and I sit on steering groups where we go through all these steps, and then they say, oh, I've done it now, so we'll just stop. No, actually, this implementation is where you need to carry on. So in pulling all this together, again, this is where I come back to the collaborative approach. So this is quite a busy slide, but this was crucial to get right at the beginning. So we started meeting everybody who has an interest in epilepsy to form a governance framework to see actually how is this going to work and how are we going to work together. What I can't stress enough is that if you need to get this right to make actually the former slide, to make the former slide happen. And it became evident actually what we need to be, we need the joint owners to be Epilepsy Action and Epilepsy Society, but working very closely with, here we've got the Epilepsy Specialist Nurse Association, that's ESNA, the National Clinical Director, David Bateman, who's championed the commissioning toolkit. NICE have been involved all the way through, making sure that actually we're aligning everything with the NICE quality standards. Public Health England, that's the Neurology Intelligence Network talking about, the Royal College of GPs, which we got endorsement from in the end of the toolkit, so that was a great achievement. And SUDEP Action. SUDEP Action worked with us actually right from the beginning, and were quite instrumental in editing and reviewing the whole content. And down here we have the Association of British Neurologists. Again, we had to make sure that they were involved, and they endorsed the toolkit as well. We had the Strategic Clinical Networks, the International League Against Epilepsy, the Royal College of Paediatric and Child Health. So lots and lots and lots of people, the Neurological Alliance, just making sure that everybody was actually coming together for the same aim. So within the toolkit, what we've got is we designed a commissioning cycle, and this has been done with 8 CCGs, 9 CCGs, sorry. And these are the ones, they're part of the 22% who are actually interested in neurology and had some experience of each of those steps. So had they been through scoping right through to implementation. And because we wanted this toolkit to really resonate with commissioners, as commissioners we need to engage to make sure that they're going to take action on implementing epilepsy services. They've been instrumental in forming and developing and writing each of the sections. So it's been myself and Perry travelling around the country and making sure that they're inputting in. So this is our commissioning cycle, and this is all where all the steps fit into. So going for the planning, procurement, and monitoring stages. We've also developed a checklist. So at each section, what are the key things that need to happen? So another group I've been working with is Southend support group. So went down to meet them, and they're actually meeting with their CCG, and they're using the toolkit. So they're from the first meeting they're having, the scope of what needs to be done, they're going to sit and actually use it and know what their rights are and what should be being discussed. And they're feeding back to us because we're open to reviewing it. So each stage, so you can print that off, and there's a checklist to use. And in each of the sections, so behind each of those boxes you saw originally, when you click into it, there's a section for tips, and these are tips from the commissioners themselves. So this is tips from commissioners to commissioners. This is what you need to do. This is what we did. this is what would help the process. Patient and public involvement, and this is on every step. Actually, what should the patient and public involvement be? There's a legal right for the CCGs to involve people. And epilepsy. So what's the information about epilepsy? We've got videos for people telling their stories about services they've got, how they live with epilepsy. So in each section, there's a range of tools. This is what it looks like. We've tried to keep the format as simple and easy to use as possible. I've certainly learnt a lot about website development, and the more information you get, the more complicated it can be, but it's actually making sure you're not too many clicks away from the information, and it's keeping all that information current. So we've got either click-throughs to sites, again, this is the data sites, or there's documents, as in the NICE guidelines, and other documents, and we've got interactive tools as well. So we're constantly asked, well, how many people have got epilepsy? In the CCG, how many people would we have, with epilepsy? We want to know the population. And we have that information. So the one quality outcome framework point we've got left is that GPs need to keep a register of people with epilepsy. So we've designed a tool which is embedded within this that you can select your CCG and it will tell you how many people with epilepsy are, and we've worked out how many that's across children and adults as well. And we're developing that further to pull through the seizure freedom data from the QOF points retired, but we've still got that information. And for nurses, so there's a big challenge about, for us to get new nurses, but also it's the evidence about actually what does a specialist nurse do, and the commissioners are often asking, well, who else can do that role? So we need to make sure that we've got that information. At the moment, we've created an impact tool for nurses. So Perry and I are going around the country speaking to the nurse group, saying, collect this information so we've got the evidence of the differences that they make. So our registered users, we've got... we're up to 195. So the whole evolution of this has happened at quite a pace, really, because we've had to have quite a degree of tenacity to actually make it happen. And we started with a group with the CCGs, with David Bateman, with Greg Rogers, who was the clinical champion for GPs at the time, with SUDEP Action, with Epilepsy Action. So we were all together in a meeting saying, okay, how are we going to create this? And that was November 2014. We then went away to work with the commissioners, the 8 CCGs, to actually develop it. We had it reviewed, and then went live by May 2015, and then had lots of review, and added more information, more tools on it, anything we could get. The other vital bit of information that we do have, which CCGs like, is sharing business cases. So business cases for specialist nurse, we've got a business case for psychology services, we've got a business case for a neurologist as well. So anywhere that we go, people have created successful business cases or service specifications. We're like magpies. Let's get them. So it's practical information that's on the toolkit. So that's another thing that can be that can be easily be downloaded. So we have targeted this originally at commissioners. So we've got 21% of commissioners, about 195 have registered to date, and we've got a variety of different people registering. Members of the public, we want that to go up. That's 2%. So by the end of it, I'll do a call to action for people to register, so we know that actually this has been used by everybody. So the results have been the CCG interests. Again, you're looking at that 22% that were interested. They're the open doors. There's 78% of people, even if we knock on the door, we've got to try and unlock the door to get in. But we're starting to get a bit of interest through now. So now this toolkit is doing its work, and it's got a lot more work to do. So working with the 8 task and finish group commissioners, and in particular We've got Camden CCG, who have set up a community service where the neurologist has come out of the Royal Free and working at Camden, and there's a specialist nurse. And we've also just commissioned a self-management programme there as well. Buckinghamshire CCG and Public Health, they've actually invited us to write, this is a few voluntary sector organisations, but for epilepsy particularly on their joint strategic needs assessment. So we've put information about epilepsy on there. Nottinghamshire Public Health, their health needs assessment, I spent quite a lot of time writing and rewriting their needs assessment to make sure it had an impact, and if they took it, when they took it back to the CCGs would do something about it. Southend Patient Branch, I've already mentioned, they're looking at it from a patient perspective and people with epilepsy and family to see actually what difference can they make. They have a visiting neurologist, they have one nurse who's absolutely swamped, so they want to get another nurse in. So we're in watchful progress of that at the moment to see how it's working. Hereford CCG, they wanted an epilepsy specialist nurse business case, so we worked with them. We had examples on the toolkit they could use. We sped up that process, and they got a nurse. They successfully got a nurse in position. And another thing to do with Epilepsy Action is a induction program for new nurses. So that nurse actually came through onto the induction program. West Essex CCG, again, they were looking at an epilepsy specialist nurse business case. They're still looking. That's taken quite a bit of time, but they were the ones that said, look, where is all this information? We want it in one place. So they're starting to make progress with that. Croydon CCG, they were looking to do a pilot to appoint 2 epilepsy specialist nurses, but they were looking to do it for 6 months. And so where we did manage to influence them was to get onto the steering group with the commissioners, with the hospital as well, and the neurologist, and to convince them, you need 2 years. You know, we were going to a year and then said 2 years to actually be able to see a difference, because otherwise you could set a nurse up to fail if you're just going to pilot them for 6 months. You need that length of time for them to be able to succeed. And again, that nurse came on the induction programme. Walthamstow CCG, they're looking at paediatric epilepsy specialist nurse. Bradford have an excellent service, if you're from Bradford, but a very good community epilepsy service where they have GPs with special interests. And what the CCG wanted to do is actually, we know it's good, we hear it's good, but why is it good? Where's the evidence? So we are creating a nice quality standard audit, a self-assessment audit tool with them, and a patient survey to come together and say, actually, this is why it's good. And Newham CCG are looking across all their children's services. So this is the start, and we want to keep it going. So some of the feedback we've had, which has been pleasing. We've not done all this work for nothing. What's particularly great success is Diabetes UK. As I said earlier, we're always following diabetes. Wherever I go, the services have been set up for diabetes. They've done this, and we're trying to follow along. But actually, Diabetes UK have seen our commissioning toolkit. I think it's clear, easy to use. So Per and I went to meet with them, and they are learning from us, which is a great feeling. And we have got Yorkshire and Humber Strategic Clinical Network. They've inputted into the toolkit as well. Hardwick CCG, they were one of the group that worked with us, the CCG. And this reflects actually the organisations working together. You know, this is what can be achieved. We're a greater force working together to achieve this. East of England Strategic Clinical Network, they were very much involved, and they were particularly looking at epilepsy services. South East Coastal CCG, it came at the right time for them. They were looking at all of their neurology services, that actually this has worked, at least that they can go in and use it all. And North East Links CCG, again, they were one of the groups that worked with us. And they particularly like the inclusion of national guidance, best practice examples, again, those examples of how things can work and across different regions. And as I say, they don't want to reinvent the wheel, they want to steal it. So they're quite happy to use other people's work, especially if it's worked. So I said, my plea to you, so this is what we're doing about it. We've still got a long way to go. It does take time, but we've now, we've been around the country, we've given talks about it, we've published about it, so it's getting recognised up there. But we want people to still be using it. And I think my plea to you is on the information stand, you would have seen a little business case, you might have seen a little business case, is register onto it. Register onto the toolkit. Go there and see what you think. Leave us some comments. And Perry and I we're really happy to amend or change anything, or if you've got any suggestions of examples of good practices that you've seen, especially in your area, we can put it in there. But equally, if you want to be talking to your commissioners, this is the way to do it. So what I want to see that 2% go up. We know we've written this for commissioners, but actually it'd be really good to see if it means something to you as well that you could be using. So that'd be great. Thank you.
Thanks very much.